candidiasis, the severe version of the toxic erythema of chemotherapy, the vancomycin-induced LABD, and I want to warn you, you may have a patient who has TEN, and then because of concern about the break-in barrier, they're put on vancomycin to protect them against Staph aureus, or even become bacteremia with Staph epidermidis, and they'll be on vancomycin, and then you'll think they'll have a recurrence of their TEN, when in fact what they now have is on top of that, they now have the vancomycin-induced LABD. And so you need to then do direct immunofluorescence and be able to make that diagnosis. And then we see acute graft versus host disease. This is to remind you about the toxic erythema of chemotherapy. It tends to like folds of the body. It will be very dusky. It will not be, it will be sterile. The bullae are sterile. And if you look at the hands, if you were to think this person had erythema multiforme, I would remind you that the lesions are in the creases, the intertriginous zones of the digits. You also, when you walk in the room and see those large lesions on both knees with a little bit of scatter around them, this is not vasculitis of the skin, this is toxic erythema of chemotherapy. Now, because many of the patients are also thrombocytopenic, they may have purpura within the lesions. The problem with this diagnosis is that it occurs up to 3 to 4 weeks after the chemotherapy, and by then everyone is blaming every drug eruption on antibiotics. This is another point. When it's in a moist area, you can get a lot of moist desquamation. I draw your attention to the fact that this is 4 weeks out from the time of the administration of the chemotherapy. And this is severe TEC, toxic erythema of chemotherapy, and it can mimic TEN. However, there's not the same fragility that you see in TEN and SJS, and then bullae tend to persist, and you actually need to drain them. One more thing in the differential diagnosis of SJS-TEN, of course, is a generalized fixed drug eruption, as we see here. And this fools people a lot because you can get large denuded areas. It can affect intertriginous zones and lead to a lot of problems. As we see here, with all these patients were considered to have TEN when we were called to see them. One of them was said that his scrotum was on fire, but maybe it was, but I don't think so. These were all due to non-steroidal anti-inflammatory drugs. So we have 4 choices. You're going to hear more about that later today. IVIG, cyclosporin, you have etanercept times 1, and you have high-dose decadron, pulse decadron for 3 days. Now, the only thing you don't want to do is give prednisone for 2 and 3 weeks, or you increase the risk of infection. The one thing that you need to remember when you walk in the room and people tell you the patient has a morbilliform drug eruption that's becoming erythrodermic is the first question I ask the resident, are there any areas of fragility? And what I mean by that is this one area that you can see where the skin is beginning to fall off is the clue that this person isn't a simple drug reaction, and this is the same patient then 3 days later. So the most important question I have is, does the patient have any vesicles, bullae, pustules, dusky centers, or particularly any areas of fragility? Dress, we all are going to hear about this. This is a patient of mine who had it due to Plaquenil, actually. And these are additional people who had vesicles, as I recommended before, for you to not be too dogmatic, because people with dress reactions can get vesicles. They can even get pustules. And this is sort of my way of thinking about dress, and that is the idea that you can have multi-organ involvement. You can have cardiac, which we read in the literature of many patients dying from that, pulmonary, liver. We usually think of liver as number 1, but you can have horrible myositis, you can have cerebral involvement, and you can have even pancreatic. I think we focus the most when we walk in the room and think someone has stress. We think about the liver, we think about the kidneys. But the reason for this schematic is to make us, yes, those are the most common, but we need to step back and think of other areas of involvement. And we know the main drugs, but the one I want to bring out the most to us, the two most common are in green, but the one that we need to own as dermatologists is minocycline. These are the criteria that are available to you. The ones that are in green are the ones that I think are controversial, because if peripheral eosinophilia we know is not in every patient, and we know that if you've been given corticosteroids, that they can be gone by the time you see the patient. So using this as a criterion is not always perfect. The other thing that I don't feel is important, and I hope there will be a revision of these criteria, is the ANA, the blood cultures, the chlamydia, and the mycoplasma. Sorry guys, okay. And then we have a final score of definite, probable, possible, and I think we need to be true to ourselves and true to those that the patient, that we're not sure they had it, but we're going to follow them as if they did. The Japanese have a different way of thinking about it, and they're really big on HHV6. I think I'm lukewarm on that one. The thing that I think is the most interesting thing that's come down the road in the last 5 years, 10 years or so, is the idea that there are people at risk based on specific HLA associations. So much so that when somebody's about to get carbamazepine, they do get their HLA tested. And when they're about to get abacavir, if they need it, they get their HLA tested. I think that I focused on SJS and TEN. Obviously, one can see vasculitis from drugs, as we see here, including medium vessel vasculitis. You can get PAN from minocycline, for example, and we need to own that as well. And we can also give patients heparin or Coumadin. Maybe they have atrophy blanche and you've decided to treat them yourself. And we can get necrosis, we can get emboli, and we can get thromboses from heparin, all by giving these drugs to our patients. This is AGEP. I'm not as nervous about AGEP as I am DRESS and TEN. That's just a personal opinion. The patients never seem quite as sick, and I'm never quite as nervous, though it makes everyone outside of dermatology very nervous. In addition, I don't get as nervous about erythrodermas from drugs because they're usually more of a subacute onset, and I feel that we can handle them as well. So those are not, that is the AGEP and the erythroderma, you will see, is not in my rule out acute bag for the dermatologist. Now you may disagree with that, but these are the ones that I include. Thank you very much for having me today.